Well, welcome on behalf of the Collaborative Research Center for American Indian Health. My name is Danielle Kenyon, and I am very pleased to help present this the Pilot Grants Program panel presentation that we have here today. But before we get started on that, just wanted to do a few housekeeping items. Due to the construction in the middle, if you guys haven't found the bathrooms yet, they're a little kitty corner over there, so you might have to walk through the atrium and around to get to the bathrooms on that side. And any of the registration tables out front will be able to answer any other questions, anything else that you have. If there's nothing else, we'll go ahead and get started. We're going to have questions in the middle, and then toward the end, we'll open it up for Q&A. So, for the interest of time, we're not going to do a long intro of each of our presenters today, but just going down the line, we have Dr. John Gonzalez from Bemidji State University, Dr. Jessica Hanson from Sanford Research, Dr. Alicia Mousseau from Little Wound School, University of Colorado, Dr. Bruce Vogt from University of South Dakota, and Dr. Jay Memmott from University of South Dakota. So the title of this is The Findings and Lessons Learned from the Pilot Grant Awardees. So we're excited, like I just mentioned in the previous presentation, we are now on our third round of Pilot Grant program. And this program is really focused on funding pilot projects focused on transdisciplinary research that is cutting edge and addresses those significant health disparities in American Indian populations in South Dakota, North Dakota, and Minnesota. So we look, and each project has to have a social determinants of health focus that leads to an improvement of American Indian health. So not necessarily bench science, but what are those environmental factors that play a role in our health? And these projects are also scored on the potential for future funding, including that sustainability and growth of the project. So again, this process that we've refined over the last 3 years, we've really done improvements and tweaked through evaluation over the years that when we released the RFA in the fall, this year we were able to give the people writing the grants 14 weeks before the release of the RFA to the deadline, which is oftentimes even more time than NIH will give you. Our external review team, we have 8 great reviewers that are external to the region, so that our CRCAIH cores and divisions can help as much as they can in helping to develop your project idea to a competitive funding program. So, and it'll be great to hear firsthand from our Pilot Grant awardees any of their reflections on the process, or if you have any other questions for them. This is totally open, but before we go to that, to give you a snapshot of their findings, we will start with Dr. Hanson.
Yes.
Each of our grantees are given 5 minutes to do a quick overview of their research design and their findings.
Yes, so 5 minutes. I can do 5 minutes. So my topic was on looking at survey validity and reliability. And so I will be talking more about the methodology as opposed to the health topic. But just to introduce, so my name is Jessica Hanson. I'm an associate scientist at Sanford Research, and I work very closely with the Oglala Sioux Tribe Choices program. And I just want, if Susan's willing to raise her hand. Our Choices coordinator is down here, Susan Poirier, and we do have a booth. So if you're interested in learning more about the Choices program, again, we've got 5 minutes, but I would encourage you to go to the booth and talk with any of the folks sitting down there. So the Choices program is focused on prevention of alcohol-exposed pregnancies, and we work primarily with non-pregnant women. And so these are women that are at risk for an alcohol-exposed pregnancy due to being at risk for an unintended pregnancy and also drinking at risky levels. And so we currently enroll participants, and this is based on a validated randomized control trial intervention that's evidence-based. And the tribe received funding to implement this with the women in their community. The Oglala Sioux tribe did. And Sanford worked on the evaluation of this. And so we got it up and running. We worked for a year or two on data collection, and we started to get little inklings of there's some problems in terms of our data collection. And this was coming from the interventionists themselves, who were concerned that, I don't know if some of the women that we work with are understanding the questions, or I don't like these questions, can we change them? And being a researcher, there are some red flags to that, because you don't want to change a validated, empirically evidence intervention too much. And so Susan and I were at a training, and we posed this to the people who created choices. Can we just sort of tweak some of these questions? And they said, no, you can never do this. This is a terrible idea. And so we said, we should definitely do this. And so we applied for funding, and we're very lucky to receive this funding. And so there's a very crucial need to determine validity and reliability with any measurements, with any population. And researchers are aware of this. Just because you write a question for one population doesn't mean it translates easily to another. And so we wanted to look at the accuracy and measurement, and also how can we translate this data to real life situations. And so we had 3 specific aims. One was to look at the content validity, and so we wanted to get input from experts. I'm not talking, we got some input from experts in the field of reproductive health and choices, but we also worked a lot with the community. Can you read over these? What do you think of these questions, and what should we change? Our second, to establish validity, we also did something called a think aloud, and I was so excited. I've always wanted to do this type of methodology. It's a qualitative methodology. And this is where you ask women or people to read aloud as they're completing a task. So it can be any task, and in this case, it was completing a survey. And so as you're completing the survey, it's hard to do, especially if someone's sitting there watching you, but we ask them to think how they respond to questions, what they struggle with, what they have problems with, what's confusing. So it's very much qualitative, and we tape record that and analyze that for kind of themes. And we started to see themes. Over and over, people have the same problems with the same questions. So then our next step was to modify the instruments based on the think alouds, based on the content validity, and then we did a test retest. So basically we had our original choices questionnaire, and then we had a modified questionnaire. And we did a test retest for both of those over a 2-week period to see our responses changing. Are people having problems with these questions? Next slide, please. And so for the content validity, we had 17 individuals locally and nationally review it. And for the think aloud, we worked with 23 women, which for qualitative data collection was good. We were pretty happy with that. And these were with American Indian women from Rapid City, and then also from communities across Oglala Sioux tribe. And made those changes, got a lot of input from our interventionists and from the choices staff, and then we did our test retest. So with our test retest, we had 79 participants. Our goal was 100. We almost made it. 44 were randomly assigned to the modified questionnaire, and then 35 completed the original. 2 weeks later, we asked them to come back. We got most of the women to come back. And so we had about a 50% response rate for the retest, which was pretty good. And so for the changes to the measurements, just really quickly, there were wording changes, such as depression. It wasn't the right word. It had a lot of negative connotations. That was one word that really stood out to women. The next was they needed context to questions. So there was one sentence that talked about being physically tense. And they kept saying, well, what does that mean? What is physically tense? Like your back hurts, or you're stressed, or we need a context to this. There was also suggestions on drink size. So what the original choices questionnaire had for drink size is not what women are drinking. We needed to change that. And then there were different questions that were confusing. So after we made those changes, the test retest, and we worked very closely with the methodology core on this. And so what they found is that the alcohol questions did work better with our modified version, which was great. So we knew, okay, let's make those changes. But with our birth control questions, those did not do as well. They did better with the original. And there weren't any other significant really differences. And so what that told us is we should have done this earlier. We should have done this type of study earlier. But but there are changes that needed to be made to our survey measurements, some changes, not all, but some, and so we went ahead and made those. And that's really was our outcome. So I think I took more than 5 minutes, so I know there's going to be time for questions afterwards, but I do have handouts of our publication related to this. I have 5 copies. I'm sure there'll be a huge fight over it, but if you do want, if I run out and you want to read this, I can surely send you the PDF. So.
Yeah. We're next. Thought we were next. Okay, you hear me okay? Our title of our project was Assessing Lay Patient Advocate Training in Tribal Communities, and it was a collaborative effort of the USD Sanford School of Medicine, the School of Health Sciences, the South Dakota Area Health Education Center, and the South Dakota Association for Lifelong Learning. And we had 3 project aims, and the primary one being to develop a health literacy lay patient advocate training program, develop a curriculum, and deliver it in American Indian communities. And the goal was to improve health literacy, to improve patient advocacy, and ultimately hoping to improve health care. And the second aim refers to the collaboration with the South Dakota Association of Lifelong Learning. These are the adult educators in the state, and our curriculum was delivered at already established adult learning center sites within the state. Our curriculum was integrated within what they were already doing. And then finally, we had a couple of novel assessment techniques that were used, I'll mention in just a minute. We originally planned on using 4 tribal communities. We ended up only being able to develop the program in 3 communities, although one of in those communities were Eagle Butte, Enemy Swim, and Sisseton Wapanel-Oyate. We did, though, end up in the Eagle Butte site. We ended up having a couple of different organizations that we worked with. And so we still were actually very pleased with the numbers that we had. Our project, the curriculum was developed by a committee which included all of the departments in the health sciences, as well as the School of Medicine, and with input also from the American Indian community, which was obviously important, both within the broader USD network, but then also at the local community sites. We developed 4 modules. One was becoming an advocate, the second was medication administration and prescription drugs, and then the third and fourth were on maintaining your balance and looking at healthy eating and then physical activity specifically. Our project manager, Dr. Cassie Gutierrez, trained the trainers, if you will, on site at the different sites, and we also had a couple of other folks that were involved with the training as well. Then the program, the curriculum was delivered by the adult educators at the different sites. We had a couple of hypotheses. The first one was that students participating in the health literacy and self-advocacy training would demonstrate increased levels of patient activation over baseline. And then a secondary one was that we'd be able to predict this patient increased patient activation. Our assessment instruments, one was called the PAM, or Patient Activation Model, which is a 13-item tool which assesses patient knowledge and skills and confidence for healthcare self-management. And then the TAM was the technology acceptance model, and we used a variation of it. We altered it to be able to look at predicting patient activation. And the TAM is a 10-item model that predicts a person's behavioral intention to make a change, to become activated. And the predictor variables are perceived ease of use and perceived usefulness, and the outcome variable then is behavioral intent. So that was the project design.
Okay, so in terms of lessons learned, we learned a lot of things as you do when you do research. And I think I'll actually start with the last one that we had listed, which is really to expect the unexpected, which is virtually impossible to do. But one of the things was to account for contextual factors such as the training sites. I think we naively assumed that there was more technology available than there actually was, and we were actually able to assist with that towards the end of the project. Also, there were things that were going on in some of the communities that had an effect. For example, the site that we ended up getting baseline data but not being able to actually carry through with the project, there were some things going on with the local college and accreditation issues that really interfered with our capacity to pursue the training because it wasn't a priority anymore. So that was one change. Securing commitment of all the stakeholders. There was turnover issues, and some people seemed to be more committed to the project than others. And I think that one of the other things we learned, we were somewhat limited because of funding, and that was to be able to provide incentives for folks. I mean, we were able to provide incentives, but I think the weight of the incentives certainly helps secure that commitment. Another thing is that in developing the curriculum, one of the things that we got quite a bit of feedback on, constructive feedback, was to develop more content that was geared toward visual learners, not just auditory learners. And I think another thing that we got from that is certainly making the modules and the learning as experiential as possible. I think that's really important. Another thing is to build in formal qualitative assessment, and you talked about your method of talk aloud, that our assessment methods were largely quantitative, and but we did receive a lot of anecdotal data, but it wasn't really built into our project to do a more systematic qualitative assessment. So I think that's basically it.
Washte, Mishomas Makomas, Nishinabe Duke, Mitu Mashtag and Dijinakas, Gawa Babi Ganikag, and Donjiba, Ajijik, and Nodane. I just wanted to introduce myself first in my native language. You have my information there in terms of who I am and where I'm from, but I wanted to say that my spirit name is Running Horse, and I'm a member of the White Earth Nation, and I'm also a member of the Crane Clan. So I've always been taught to do that whenever you're addressing people, and particularly if you're in another tribe's land, so that the spirits know who's talking and so on. So there's a title of my project I did is My Healthcare Making Me Sick, Microaggressions in American Indian Healthcare. And this project really came out of some work that I was doing previous to this with American Indian students on campus, where I'm at Bemidji State University, and looking at their racial discrimination experiences. So microaggressions is basically this $10 research work that someone came up with to talk about the very subtle forms of racial discrimination or discrimination in general that happens to marginalized groups and members of marginalized groups. So I was doing some work with students on campus, trying to understand what their experiences were around race and racism and discrimination, and did some focus groups and a few other things. And as part of those focus groups, the students would share lots of different experiences that they've had, not only on campus, but in the community as well. Right, in Bemidji, if anybody knows where Bemidji is or has been to Bemidji, it's a border town, much like Rapid City is here, right? We have 3 Indian reservations that surround Bemidji, and it's quite a large native population there. And there's lots of racial discrimination that actually happens there. Some of it's overt, your old-fashioned racism, but a lot of it is sort of hidden and covert and so on. So people would be talking about experiences that they had in the community, so with that, there was experiences that they talked about having in the healthcare system, and I even have some of those in my own family and stuff as well too. So the project aim were to basically try to identify what were the types of microaggressions that Native people experience when they access the healthcare system, to try to understand what those were, and then how are those things, related to wellness and health outcomes and so on. So, what I did is I obviously one of the first things I did was approach all of the tribal councils, the 3 Indian reservation tribal councils, and got letters of support for those to go ahead and do this project. And I established a advisory board. It was made up of actually a couple of physicians at Sanford Health right there in Bemidji, and some community members and stuff as well too. And then once we got funded and so on, what I did was we conducted 4 focus groups, and we separated them by gender. So focus groups for men and then focus groups for women. And basically had people, ask people to come in and share their stories, and of course there was lots of stories. Some of them were, again, you're pretty blatant over racism, discrimination, but there was a lot of very subtle things that people talked about in terms of their experiences when accessing healthcare and how that affected them, and in terms of their utilization of healthcare services and so on. So we did the focus groups, and then out of those focus groups, we developed and put together this interview protocol based on the focus groups. And the interview protocol had about 22 different types of experiences that focus group members talked about experiencing. And so then we interviewed 50 additional people, separate people from the focus groups, using that interview protocol to try to understand how often are these microaggressions happening when people go and access healthcare services. I think that's basically what I have up there, right? So in terms of our findings, again, there was 22 different types of microaggressions that sort of came out of those focus groups. And you can see there, in terms of the prevalence rates, those were the 50 additional people that we interviewed. You can see that almost all of the sample experienced at least one of those microaggressions, and then significant numbers, of the sample experienced a lot of microaggressions, 10 or more, 5 or more, and so on. So they're happening a lot, right? And let me just give you a couple of examples of what those microaggressions are. They ranged from the front desk staff or the nurse or the physician having what they would identify as a negative or a bad attitude because they were Native, being treated like they were a drug addict, being talked down to was actually one of the most prevalent ones, meaning that the nurse or the physician would talk to the patient like they didn't know anything about them. They didn't know anything about health or wellness, or didn't know their body and things like that. There's one specific example of a woman, in fact, who was having some lower back pain, and they insisted that she was pregnant and wanted her to take a pregnancy test, and she insisted that I am not pregnant. I know I'm not pregnant. That's not what's wrong here. And sure enough, later that it found out that she had some kidney stones in it, and she was not pregnant. Okay. She knew she wasn't pregnant. So those were some examples. There were lots of those examples where they would just they treated them like they didn't understand health or wellness or didn't know their bodies and so on, and so on like that. So there were again, you can sort of see some of the most common ones up there. They were listed in terms of the number of the 50 people who reported experiencing those types of microaggressions. And then I did some multiple regression analyses to try to understand how these microaggressions and some other variables were related to things like wellness, and chronic pain was actually the most common health concern or health problem that participants reported experiencing. And so those are the different factors and variables that were predictive of wellness, using the scale that I used, or the measure that we used, and then those variables up there are the ones that were predictive of chronic pain in the sample as well too. So, language.
Alright, so my name is Alicia Mousseau. My parents are John and Vera Mousseau. My grandparents are Lena and James Mousseau from Porcupine. And my godparents are Howard Brown and Karen Spoon Hunter Brown from the Wind River Reservation. So we did a project, a school-based mindfulness project with American Indian youth, and we were looking to see if it reduced substance use and risky sexual behaviors. So my first, so I put up my specific games just so that we could go through it that way. And the first one was to pilot the mindfulness curriculum among American Indian students to determine feasibility, refine details, maximize fit within the community. And so we learned a lot about implementing the mindfulness curriculum in a school. And we chose the mindfulness curriculum just because there's a lot of different issues that youth face, American Indian youth face. And mindfulness is not a panacea by any means, but it's a good skill for youth to have and to utilize in different situations. It's mobile, it's cheap, it's free. I mean, monitoring your breath, you can do that at any time. So we chose mindfulness, which I'll give you guys a definition. It's a non-judgmental present moment awareness. So it's just being present in the moment, non-judgmentally, which is key. So we utilized the curriculum called Learning to Breathe. It's by Patricia Broderick. It was just put out right before the project started. So we utilized that, and it's 7 sessions, and we put it in the health and PE class and made it available to all the high school students at the school. And some things about piloting it and the feasibility of it, there's some things, the key things we learned. One of them was classroom availability. Some of our schools are very limited on space. We barely have space for classrooms. So the school that we were at did not have a classroom for the health and PE class. They had a whole gymnasium. And doing a mindfulness class in a whole gymnasium, that's actually like the center of the school, so people walk around it all the time. We couldn't have it in the gymnasium, so we had to find a classroom, which was in the basement, like way in the corner. So that made it difficult. So we learned that we need to find a classroom that's close so that we don't lose students on the way to the class, and it's not necessarily in the basement, like a suitable place for it. Some little things that matter. Second thing is management of a research project in a school. We did this program through a school which doesn't yet have the capabilities and capacity for a research project. And those things can be developed. However, when you're running a whole school, you have teachers, you have, it's a K through 12, so you have K through 12 staff, the policies and procedures of the school, how do the scientific projects fit within that. So figuring that out better would be super helpful, or just having a research center or university do the project and not necessarily have it run through the school would be helpful, just because of those little infrastructure things that aren't necessarily set up yet, but possibly can be through programs like CRCAIH and other capacity building projects. Third is conflicts of interest. If you work in a reservation and you are from that reservation, you know almost everybody there. So people know people. So there's always, not always, but conflicts of interest, you should always be aware of those, because just knowing other people and their connections to other people. So learning how to work around those conflicts of interest is another thing we learned. The fourth thing is facilitator mindfulness background and openness to mindfulness. The research says that your facilitators need a background and their own practice. I wanted to see, since it was a pilot, I was trying to see what all we could figure out. So see if we could recruit people and teach them about mindfulness while they're teaching the students. I should have listened to the literature. The literature was pretty spot on. If your facilitators have a background already and have that fostered, it's much easier for them to implement it with their students and share that experience. So that's something else we learned. On the program evaluation and research, this, like I mentioned earlier about the management and schools not necessarily being set up for research. So doing the evaluation and research pieces in addition to school, like their Dakota step testing or whatever school testing they have, it's another thing added on to them. And not really understanding research, sometimes there can be roadblocks with that. So educating the schools and different programs we work with about what research is would be super helpful, and also would help the ease of implementation. So the next slide, please. Our second specific aim, so down to the meat and potatoes, was to examine the effects of mindfulness on risky behaviors, including substance use and unsafe sexual behaviors. So students in the mindfulness, we had 3 cohorts. We did cohort 1 and cohort 2. Cohort 1 happened in the first semester, and cohort 2 happened in the second semester. And cohort 1 had significant increases in smokeless tobacco use compared to those who did not have the mindfulness curriculum from time 1, time 2. So something we didn't expect, and kind of need to talk that through a little bit to figure out what happened there. But other substance use and unsafe sexual behaviors were not significantly different in cohort 1 or cohort 2. And then from time 1 to time 3, so across both cohorts, there was no differences either. So it was only in that cohort 1 from in the fall semester. Our specific 3 was to examine the effects of the mindfulness curriculum on retention. Retention was not able to be examined because our school's software was not accurate. The school we had its own tracking software for attendance that teachers would put the attendance in. When we sat down to look at that attendance and try to figure it out, the numbers were not adding up no matter how we did it, which didn't make sense to us. It kind of boggled my mind and kind of scared me, because if you have a database, how is it not adding up and how is it not accurate? We had multiple people check it, so we were not able to look at specific aim 3 just because of we found some glitches in the software that was being used. Specific aim number 4, gather data and prepare for a randomized control trial to implement this across different schools on the reservation. And so we gathered data at 3 time ports. Data was not consistently collected during the 3 time points, which is more lessons learned. So we have a small number of participants. However, we have some baseline data that was pretty helpful in understanding how mindfulness works in our youth. So we may be utilizing that. So thank you.
Thank you, Alicia, and the rest of the pilot grantees. Right now, we will open this up for question and answer time. First of all, are there any clarifying questions or questions on like the content of the projects, of any of the findings or design? Yes.
One for, I think it was Dr. Vogt. Did you say something about weighted incentives? Somebody talked about incentives for people to participate. And then
I turn it on.
Okay.
Could you repeat the question?
Sure.
This one works. No, it's
That
not
didn't say that. There were some small incentives, some gift cards, $25 gift cards that were used. We did assessments baseline, and then 2 weeks later delivered the curriculum, and then 4 weeks and 8 weeks later assessments were done again. And if the participants participated, they were given a $25 gift card for that. We kind of skipped right over our findings, but there were 220 participants in the program, and bottom lines were that patient activation did increase, and also that there was good intercorrelation between patient activation, behavioral intent, perceived ease of use, and usefulness. And then the greatest predictor of patient activation was ease of use, basically, of the curriculum.
Dr. Hanson, you had indicated that the term depression had a negative connotation. I was wondering, how did you change that, or did you work with community members to come up with ideas on what they wanted?
Sorry.
That's okay.
Sorry.
So the question was about the term depression and sort of how that was seen. So we tried to stay away from the clinical use of depression, and so we changed it. I can't remember the wording exactly. I'm sorry. It actually might be in the article. I'm not kidding. So we tried to stay away from, like I said, the clinical term. So we said the statement was unpleasant emotions. If I were depressed in general, if everything were going badly for me. So that was the original one. And the new one we worded as, how tempted would you be to drink alcohol if you were feeling stressed, upset, or just down in general? So we wanted to make it more wording, and these were wording suggestions made by participants and also our content folks that said, make it more general and don't make it a clinical diagnosis of depression, because that's not something, it's not an area where women feel like, well, it's okay for me to be depressed, and we just wanted to make it more general. That's a good question.
Yes, in the back.
What advice would you have for prospective pilot grantees?
I think you can all answer that, but start at the end.
I mean, part of it, I think, depends on the nature of the project and sort of the topic area and that kind of thing there. But I know that for mine, I think, what probably the most important thing is really making sure that you have those relationships with, the interested parties, relationships with community members, with the different agencies and things like that, because that's probably some of the most work that's involved, right? Is and especially if you're not, there's listening to Alicia up here about being a member of the community and how that sort of that's interesting as well too. If you're not a member of the community, there's pros and cons to that, but then there's also pros and cons to being a member of the community in itself and working in your own community and how you're looked at by different families and things, like you all know what I'm talking about, right? So, but relationships is probably the biggest thing. I think the biggest factor, especially when you're doing community-based kinds of work and working with tribal communities. So,
one of the things I was going to mention, and we are planning on expanding our project, and we've had a couple of conversations with folks at the University of Oklahoma and with their Native American Center. And of course, there's a very large population of American Indians in Oklahoma, and we're also talking with folks at a couple other schools. But one of the things that came up was that their tribal center has an elders program, and not familiar with all the details of the elders program, but one of the things we talked about is, gee, it would have been neat if we would have had some elders who actually were involved in becoming trainers for our curriculum. Now, there are issues of teaching certification and all those sorts of things that would have to be done, but you talk about what would be very likely very quick buy-in by the population in a given community if elders were involved. And I think that would have been a great thing for us to do, and something we've talked about as we expand the project.
The only thing I would want to say is to reiterate what Dr. Gonzalez said is we were very lucky. So we work, obviously OST Choices is an existing program, so we had, when we were recruiting, it wasn't this strange new program and the strange lady coming here to recruit. We worked very closely with Choices and had our interventionist Jackie work with the person collecting data to recruit. So that was very helpful. However, when we collected the data, when we did the think alouds, it was nice to have the person collecting the data. She was a nurse. She very comfortable working with the community, but she's not from there. And I think that let women, in my opinion, be a little more open. They didn't feel like, well, I know this person and I don't want to tell, I don't want to seem like I don't know what I'm talking about. Whereas Cindy's a nurse, you could tell her anything type thing. So in that way, we were lucky that we worked closely with the folks from the community to recruit. I think that helped a lot with our recruiting. But then when we collected data for us, it worked best to have someone who was not from the community. I'm not saying it's like that for all projects at all, but for ours, it was very helpful.
I guess generally I would just say be open to learning, because a pilot is a learning process. So whenever you are writing up the pilot, just kind of think of all the possibilities. You can never really think of all the possibilities or things that will happen. But always talking them through with your community partners to see kind of like how do you think this will work beforehand, and then putting that in your application to kind of put it out there, and also just be ready for whatever happens.
That's so true, and Dr. Hanson mentioned earlier about how their surveys changed, and that happened with us too. When the trainers went out and our researcher went out, there were things they learned from the local community and the teachers there that I don't think this is going to work, you should change this. And so certainly our survey, our instruments changed based on that input.
You mentioned in the Choices program that you had a perceived problem perhaps from within the staff that led to the research question, but in the other cases, where did the original research question originate? Did it come from the community at large, or was it something that occurred to you as an investigator and was compatible with what you thought you would be interested in?
Great. So just to repeat the question, then we'll kind of go down the line. The question was, where did the original research question idea come from, and was this in collaboration with the community? How did it kind of refine over time?
Yeah, my idea came from the community, and I think the question is, where did the other ideas come from?
I'm not sure. Was it directed towards? I think it was directed.
I thought it was directed toward you.
Oh, if the question's
No.
for me. Yeah, it's not, but
Okay.
So, and John
Started
also
with your
talked about it a little
example.
bit in his presentation, that it was in your work with the students, and what you were hearing in your classes, that this discrimination was happening. So you kind of answered that too, maybe the two on this side.
Yeah, I mean, I think that when we saw the call for proposal, and Dr. Vogt has been working with, of course, he's now honorably retired, but I mean, this whole issue of health disparities and looking at improving health care for Native Americans is one of the issues that cuts across all groups, but it's especially a problem with Native Americans, is health literacy. And so I think it was in some ways just a very obvious thing to do, and it fit with what Kirk wanted folks to do with their projects or pilot projects. The other interesting thing about our project is that we sat down. I think this was actually before we discussed this specific idea. I convened a group of researchers at the university and basically said, we need to start collaborating. So there was a sort of another level from an institutional perspective and our commitment to working with Native Americans, that we wanted to assemble a group of researchers so we could talk about things that we might do together to collaborate, that would be useful, that would have, it would be very pragmatic, very practical kind of focus of the research. And it really goes back to some other issues in terms of long-term relationships with the tribes and with the people, that I really firmly believe that we don't want to be imperialists with our research. We don't want to just go into communities to do research because that's what we do. We want to go into communities and do research because we have relationships with people who can tell us what is important to them, and then we can help them do that. And that, I think, was really a central thing that we started with our project.
I'm going to say another thing was a connection. One of the individuals in the AHEC program, sister happens to be the executive director of the South Dakota Association for Lifelong Learning, and we were talking about things. Talked about this issue and this concern, and about being able to deliver it in the communities and by people that first of all, we're professional educators, but also within the community, and we're well known within the community and respected within the community already. And that proved to be a real important collaboration.
And I just want to say a couple of more things about that as well too. I mean, it did, come out of the research with the students around microaggressions and their experiences on campus. But like I said, there was also some, some personal family experiences that we had. My father was diagnosed with cancer when these are going back now about 14 years or 15 years ago or so, and after he was diagnosed with cancer, it just seems like that he didn't get the best health care. I mean, he was, he would get most of his health care through IHS on White Earth there, and it just seemed like after that his health just kind of deteriorated. I mean, it was prostate cancer, and he was older, and most older men actually will get prostate cancer, and they usually die from something else besides prostate cancer, right? I mean, prostate cancer usually doesn't kill people unless you diagnosed with it really young. But it just seemed like there was always these little things that would be happening. And back then, when I was an undergraduate, and I didn't really sort of understand or have a language to kind of talk about it. But I remember many times I would take him to the clinic or to the hospital, whatever, and there'd be a white doctor, and he would come in, and my dad's sitting there in a robe, and by that time he was wearing a catheter and those kinds of things, and the doctor would say something, try to, some bedside manner or whatever, but he would say things like, how's it going today, Chief? Little comments like that, that's microaggression right there. And just think about that sort of power dynamics and things that are sort of happening in that relationship between you and your healthcare provider. And we've got this old man, who's actually pretty well respected in the community, and he's kind of famous. His name was Jim Iron Legs Weaver, if anybody knows who that is. He was an activist, and he did a lot of things to try to improve Native people's lives and so on. And then you've got this young white doctor, and things like that, right? I mean, it just, those things take their toll over time, and that's sort of how important and how I think it is this kind of, and Native people have been having these experiences when they go to the doctor for a long time. I mean, they have them all over. I mean, every single day, we experience these things, and they really do impact people's. I mean, this is coming at it from sort of a stress paradigm, right? We know what stress does to the body, and we know about daily hassles and daily stress and those micro stressors we have. And microaggressions are one more type of stress that Native people experience that has physiological effects on our bodies, and that's when I saw the sort of call for the projects and the grants, looking at social determinants. I mean, that's a social determinant. And one of the things that I heard in the focus groups, but then when we were doing the interviews, is that that prevents Native people from going to the doctor. They don't want to go back to the clinic or to the hospital when they're not treated well. When they go there, they end up talking with their feet, right? And then they don't go to the doctor until it's too late, right? So I mean, I think it plays a much larger impact on health, Native health, than we actually give credit, to in terms of the subtle forms of racial discrimination that happen.
So our project came from the school directly. They wanted to start a program for behavioral health and wellness for their students so that they could get a holistic education. They asked me to head it up, and so a lot of schools use the response to intervention, the RTI model. So we developed, there's one out there actually for behavioral health. So we utilized that for the department, and then in there was the mindfulness curriculum to give to kind of a broader spectrum of youth. So it was more of the tier 2, tier 1, or tier 3-ish, where everybody gets it. And they didn't really know exactly what, but they just know there's a lot of things going on with their youth. So we decided to kind of pick something that was kind of far-reaching, that could help with emotion regulation and distress tolerance and things like that, and mindfulness. has been at the forefront kind of right now in the literature for especially being implemented in schools, so that's what we decided to use.
So I am very inspired. I think all of these projects are awesome, so thank you. I'm glad to see them here. But I was going to ask about, the work that you're doing is trying to break this cycle of stagnation where there isn't much improved health outcome. And so if you don't have the context from Dr. Vogt, Memmott, and Mousseau's projects where you have kind of thoughtful consideration and education and contextualizing kind of almost each community about how they work through those processes. And then if you don't have the correct instrument, I'm sorry, I'm forgetting your name, instrumentation to pick up that data capture or take into account some of the social interaction stuff, you really can't break that cycle of doing a lot of inappropriate research and not having a measurable improved outcome. So, but the problem always remains is dissemination. So, when a lot of these Native people go to off-reservation health places like hospitals and stuff in Bismarck and here in Rapid City and stuff like that, how much do you think those places are taking up some of your research? And then the other dissemination is in Washington, D.C., when they want to fund a project like this, you run into, well, you don't have anything to back up your data in the literature, and so you're kind of in a catch-22. You are creating the data, but then they give you a grant and you need more data. So dissemination, I think it's great what you're doing, so you have to kind of break the wall for the healthcare system, and then you have to break the wall for the funding agencies. So how do you feel your work fits in there?
One of the things that CRCAIH is obviously doing is putting this information out on the web, like the presentations that we made, the 5 original pilot grantees this year. That information is available. With our particular project too, the South Dakota Association for Lifelong Learners, their association has a link to that presentation as well. But that's obviously, just a small part of it, and needs to be addressed, constantly. And I can only hope that with research centers like CRCAIH that there's going to be this repository of information that is going to be able to be disseminated widely, as I know is being done now.
Yeah, and I think in terms of your question about funding, so we've been lucky to have grants like this and smaller pilot grants. So now we've collected a bunch of almost like mini grants. So when we apply for a larger grant, when Susan and I apply for a larger grant, we're able to have this. We have a community needs assessment. We have a sort of more qualitative analysis. So we've gone for some of the smaller ones so that now we can go for the bigger one. And in terms of dissemination, the results from our study is very specific to the community we work with, but the methodology is something that I think could be transferred. So choices, for example, was to be, if Rosebud Sioux Tribe came to us and says, we love choices, we want it here, it's like, okay, maybe we should do this before we, sort of that formative work before we do it. So I think the methodology is something, the results are very specific, but the methodology could be sort of transferred to future studies. I don't know how to answer your question about healthcare. I think that's a really hard one. So,
it's, he's right on point about, what he's talking about is making sure, to try to ensure that the work that, we're doing and the work that other folks are doing around American Indian health is actually getting to the health providers. That's probably the most challenging aspect of it. I actually presented my studies, my findings at the hospital in Bemidji. One of the, two of the physicians, one of them has left now, but one of the physicians is still there who works at the hospital, is on my advisory board. So, you know, he invited me over there, and I'm probably going to go back as well too and talk about it. And, you know, you try to reach as many people as you can. I mean, you know, publishing is obviously another way, and I mean, it's a challenge for some of us, maybe a lot of us, to get published. You know, I mean, it's just finding time. I work at a small teaching university. I teach 24 credits a year, so that's always a challenge for me, trying to find writing time. You know, but that is one of the most important things, is getting it out and trying to ensure that, especially if we're talking about healthcare, in mine in particular, I mean, you know, we want healthcare providers, people who work in hospitals, people who work in clinics, to really understand how their subtle, you know, their daily interactions with you know, with their native patients is potentially harming their native patients. You know, so.
Should note that along with when we gave our presentations to the Sanford research group, that was also a video conference to the entire system. And I think, Danielle, I think I remember you said there were like it went out to like 700 emails, you know, addresses to be aware of it. And I don't think we had 700 listening to us, but maybe many of them went to the website afterward and such. So I think that's another way that I think everyone is hoping to do this. And we're now that we have all our data, are working on manuscripts too, for the broader academic community.
As a community-based researcher, there's not very many researchers who are based in their communities. So I'm always thinking about how my community, also disseminating to my community in different ways. And I think NIH and different granting agencies are progressing, but we also need to progress our communities and get them on board as well, and let them know what's going on, and do that more effectively. And I'm still learning how to do that, being based in a community. So one would think if you're already there, it should be much easier, and it is. It's way easier, because I can go find people, they can find me, things like that. However, there's larger capacity things that need to be done for sure, and those are things that I think about as well, and try to figure that out a little bit better.
Could I just add one note too, and that is that your question really speaks to a lot of wisdom in terms of thinking holistically. I mean, that, of course, the term we would use for it, but I think that what's represented here is a kind of an interesting spectrum in terms of the kind of situation you could describe, because you've got healthcare providers who engage in microaggressions and forms of discrimination. In many cases, it's implicit, and they may not really be even aware that they're doing that. In other cases, it may be more blatant. By the same token, part of the problem with healthcare is people don't understand what kinds of questions they need to ask. They don't assert. In some cases, they don't advocate for themselves. Or they don't bring a family member with them that can advocate for them. I mean, there's a whole host of different factors that are at play that result in poor care and poor health outcomes. And they're worse than any other population or any other group in the country. And I think that it maybe goes back to answering the question for folks that are considering doing grants, and that is to think holistically about how your project fits in. And then you really raise some good questions about how are you going to disseminate your findings so that you get the biggest bang for your buck. Because it does us no good to do research and then no one uses it. It does us no good to do research and it doesn't help people. And I realize that there's room for pure research and things that don't necessarily have an immediate application, but I don't think that the types of projects that we're talking about here, and the projects have been funded for year 2 and year 3, they really need to be targeted and have some clear purpose and have outcomes that have an impact on health outcomes.
Well, I guess what I'm trying to get at is a little bit of resistance to whatever you do disseminate. So if it's a cultural or genetic outcome that's very irregular, outside the norm, or if it's an or it's a resistance to the idea that there might be some interactions in the waiting room or in the exam room that might impact it, where they resist it. Even though you have the data, they don't want to change. So you have to break all of these barriers that are really difficult, regardless of whether or not you have data or papers or kind of a broad plan for dissemination. It's just this kind of unspoken resistance.
Well,
I think
hopefully we can, hopefully we can pick up on that conversation and you'll have some insights in your next presentation. And I think that's a great note to wrap up on, is that challenge of dissemination and hearing the next steps for our pilot grantees and really pushing ourselves to get those findings out there to make a difference for American Indian Health. And please join me in thanking our pilot grantees for presenting such great findings. And